Good afternoon and welcome to today's webinar, Measuring Quality for Program Improvement, hosted by the Blue Shield of California Foundation. This is the final webinar of a four-part learning series on local programs for the remaining uninsured. This learning series has included webinars on program development strategy, benefits and financing, and eligibility for and enrollment in local coverage programs. My name is Bonnie Madura, and I will be your moderator for this webinar. Before we get started, I want to go through a few housekeeping items. To avoid background noise, all callers will be automatically muted throughout the webinar. If you would like to ask a question during the course of the presentation, please do so in the question window on your screen. We will do our best to address your questions at the end of the presentation. Also, just remember that today's presentation is being recorded and will be archived in the Foundation's website. Please tell your colleagues who are unable to attend so that they can still benefit from the presentation and discussion. Now, I'd like to turn it over to Carolina Gutierrez from the Blue Shield of California Foundation to say a few words. Carolina?
Good afternoon, and thank you, Bonnie, and of course, all of the speakers. I am Carolina Gutierrez, a Program Associate with Blue Shield of California Foundation, and I am very pleased to welcome all of our attendees to this, our fourth and final webinar. So why are we focused on these issues? As many of you know, the Affordable Care Act, which is only the latest of a series of changes in the healthcare landscape, has managed to significantly reduce the number of uninsured. Yet today and in the coming years, we know that there will still be several million Californians who remain without health care coverage. And projections show that up to half of those will be undocumented immigrants. Because there's no national or statewide policy that fully addresses these coverage and affordability challenges, California's counties have really stepped up to create individual approaches to meet the health care needs of those who remain uninsured. And within this space, the Foundation has played a role by supporting a group of teams in communities across the state that find themselves in various stages of designing, planning for, or implementing coverage programs for uninsured residents and or undocumented immigrants. And in part, in response to requests from this group, we have pulled together speakers who can elucidate best practices and lessons learned from their own experiences in focusing on these coverage programs. As a brief recap, as Bonnie mentioned as well, we kicked off this four-part webinar series on March 30th with a focus on developing the essential building blocks to get a program off the ground. And we continued the dialogue in April around program structure and coverage services. In May, our invited speakers discussed eligibility criteria and enrollment strategies. And in response to questions raised in prior webinars, as well as the timeliness of children in California being eligible for full scope Medi-Cal, the May webinar also touched on how SB 75 might impact enrollment. Now we will hear from speakers in three communities around data and quality measurement to improve programs. And I just want to take a moment to thank you all for your interest in supporting these issues alongside the fantastic partners that you will hear from shortly. So please enjoy this webinar.
Thank you, Carolina. I'd like to take a moment and introduce you to our speakers for this webinar. First, we have Alice Kurniati, Manager in the Office of Managed Care for San Francisco Health Network. After Alice, we will hear from Shailani Alex, Senior Management Analyst for Alameda County Healthcare Services Agency and HealthPAC, and Cheryl Northfield, Principal of CNC Advisors. Then we will turn to Monterey, where Maura Knoll, Project Manager for Clinic Services in the Monterey County Department of Health, will be our final speaker. With that introduction, let's get started. Alice?
Great. Thank you, Bonnie. So my name is Alice Kurniati, and I will be giving a little bit of information about our indigent care program, Healthy San Francisco. So I just want to provide a little background on the Healthy San Francisco program. The Healthy San Francisco program was created through the Healthcare Security Ordinance that San Francisco passed in 2006, and launched officially in July 2007. It was San Francisco's transformative approach to fulfill our obligations under the Health and Safety Code to care for the indigent. The program provides coordinated and comprehensive access to healthcare services regardless of employment, pre-existing conditions, and immigration status. It is open to everyone who meet the program's eligibility criteria. Participants enroll with the program are assessed a participation fee based on a sliding income scale, which many don't pay any if they are below a certain income. And they can select from a various medical home throughout the city. The program, while not health insurance, does offer many of the benefits similar to an insurance product, including customer service and a complaint and grievance process. So who is eligible for Healthy San Francisco? It is open to anyone who meet all of the following criteria. First, they need to be a resident of San Francisco, at least 18 years old, not eligible for full-scope public benefit programs, which we are predominantly talking about full-scope Medi-Cal, not insured in the last 90 days, and have an income of less than 500% of FPL. Since the beginning of the program, Healthy San Francisco has always valued the importance of transparency and accountability for the program. And a big part of that transparency is to collect comprehensive data about our patients and present that data to our stakeholders in the form of a comprehensive annual report available to the public through our website. First, all applicants must apply for and be determined eligible for the program before they are enrolled. And as a part of that application process, the program collects detailed demographic information regarding participants, including their ethnicity, language, address, income, and while not required, we do collect immigration status for those who choose to provide such information. The program also collects utilization data through encounters from our network providers. Encounters allow the program to understand participant service utilization, including outpatient, inpatient, emergency room, behavioral health, and pharmacy. It allows us to look at outcomes such as readmission, avoidable ED, and potential diagnoses that our patients and members have. And included in the annual report, we also provide cost data, including data that are to provide the services, the program administration, and revenues that are collected to support the program. And we do provide an estimated PMPM calculation for the program. In addition to all of these data, we have always been interested in the experience of our patients, and we collect patient experience data in several ways. First, we conduct participant questionnaires to all participants at enrollment or renewal, and we ask them for their perceived health status, access to care, as well as their insurance status. We also track participants' grievances and complaints to identify trends and barriers that participants are facing in accessing the care that they are entitled to. So from all of the different sources of data, first and foremost, we hope to evaluate the program's performance and outcome as to whether or not the program is able to accomplish its objectives and goals, and to use that data to make improvements to the program so that we can benefit our participants. But in addition to using the data we collect for program evaluation and continuous quality improvement, the data we have collected from the years of the program have also been very valuable to us, providing decision support to our department's leadership. And so I'd like to just highlight a few examples of this. During the lead up to the ACA implementation of Medicaid expansion and the rollout of the exchange, having the majority of the uninsured population in San Francisco already enrolled in our program allowed us to plan a much more effective transition. We were able to utilize the data to estimate the number of patients eligible for expansion and design targeted outreach to these participants. We are also able to track and monitor patients that have transitioned into the Medicaid expansion and observe their utilization patterns under the new ACA programs. The data was also utilized as part of our internal analysis for discussions with health plans for our delivery system to join their network in exchange products and other products available. The information is also available to the public to utilize, and we have also seen several types that they have used it for. Oftentimes, we have students and other research groups that are working on health access for immigrants or undocumented population who have used our annual report as part of their research work or advocacy. Also, in the post-ACA environment, there are other jurisdictions that have reached out to us and have expressed interest in creating something similar to Healthy San Francisco to address their residually uninsured population. And the data that we're able to provide through the annual report has been a helpful tool for these jurisdictions in thinking about how they might want to design their own program. Lastly, the data is very useful when responding to media inquiries and requests, and having this annual report provides an efficient and accurate response to data-specific questions raised. And so, although the program gathers large quantities of data, we face issues of both incomplete and inaccurate data. One thing is that HSF, Healthy San Francisco, does not provide any out-of-network services and does not pay any claim from such providers. Thus, Healthy San Francisco patients who receive services at out-of-network facilities, particularly those outside of San Francisco, we would almost never be able to capture those visits as part of our utilization or cost data because there is little incentive for the facility to provide us that data. Also, some services are covered by other programs, such as certain family planning or cancer screenings that are not billed to our program. Thus, those services will be billed under a different program, and so we are never aware of those services or the cost of providing that service. The second challenge that we face is that utilization and cost data are self-reported, and the program does not do quality control on the data or to verify its accuracy. Different facilities may report data slightly differently, particularly such as cost data, where some facilities are on a fiscal year reporting cycle and others may be on a calendar year or their own fiscal year. We have been trying to improve the quality of the data over the year, but for a program that is an indigent care program, and as the number of patients decrease due to the new options available, the business case for providers to focus on improving data quality for our program may not be the same as it was prior to the ACA. When we have incomplete data or inaccurate data, we risk painting a picture about our participants that have artificially low utilization or cost. For example, based on our data, we would almost have zero out-of-county utilization and very low utilization for breast cancer screenings, when in fact our patients are utilizing these services. Even though we try to describe these caveats in our report, the outside reader may not understand these details within our data and draw a different conclusion. And so with that, I would like to just turn it back to Bonnie.
Great, thank you, Alice. Now let's turn to Shaylani Alex and Cheryl Northfield to learn how Alameda is measuring their program.
Thank you. Good afternoon, everyone. My name is Shaylani Alex, and I'm a Senior Management Analyst with the Health PAC program in Alameda County. Just a quick note about what my role is with the program is that I basically provide general data reporting and monitoring support for our indigent care program. So our discussion today is going to focus on our agency's data collection and consumption process for its safety net program, which we call Health PAC. And that simply stands for the Health Program of Alameda County. So for our presentation, we'll focus on answering two main questions. How do we look at our data, and how do we use our data? But before we do that, let's first start with a brief overview of what the Health PAC program looks like. So as the slide says, Health PAC is a comprehensive health access program for low-income uninsured Alameda County residents. It's been formally in place since July 2011, and it's also important to note that Health Pack is not an insurance. At its peak, there were about 90,000 individuals in Health Pack, but ever since the implementation of the Affordable Care Act, Health Pack has steadily maintained approximately a little over 33,000 enrollees at any given time. In terms of the eligibility criteria, you must be an Alameda County resident at or below 200% of the federal poverty level, also not eligible for full scope Medi-Cal or insurance, so in other words, covered California. And the way that individuals can access this program is to meet with health insurance technicians, or HITs, who are available to assist with enrollment at either the local medical center or at our Alameda County Health Care Services Agency offices. A little bit on the demographics. I call them fun facts. They're just like flash demographics. The median age of our population is 35. In terms of the gender, it's pretty much equally 50% male, 50% female. And ethnicity, about 94% identify as Latino, and primary language indicated about 66% are Spanish speaking. In terms of federal poverty level, approximately 79% or 138% or below the federal poverty level. As far as the services are provided, they mirror Medi-Cal benefits. So this includes a suite of physical health, access to a suite of physical health services, behavioral health services, and some dental, although this is limited wherever it's provided. And services are delivered via a contracted provider network across the county. So that includes 9 federally qualified health centers, which includes 2 hospitals too, and that's about a little over 40 sites across the county. So we'll look at our first question of how do we look at data? We'll approach this from 3 different perspectives. First, let's talk about the types of data that we collect. We look, similarly to San Francisco, we look at utilization data through encounters data, which are claims-based, and that's a little bit important to note because there is a little bit of a lag in the data. We do also collect and look at some limited cost data, again, because that's claim-based, that's really in the form of charges. And then we also want to look at data for the purposes of care coordination. So recently, Alameda County has embarked on an effort to ensure that physical and behavioral health data exchanges were happening specifically for their specialty mental health visits. So we wanted to look at that data to allow us to answer a range of questions such as who's had a specialty mental health visit in the last month but no primary care visit in the last 12 months, what kind of chronic conditions are affecting this population, who are some of the high users of these multiple systems between these 2 systems, and then conversely, there are certain providers who are carrying a bulk of that, that load or highest volume of patients or visits, and also where is this happening. The second piece that we want to talk about is the workflow process. So really asking, how do we get this data? Every month, our contracted providers upload a monthly utilization data file to a secure FTP site. And once we get the data, we run through a fairly sophisticated cleaning process, like a QA process on our end, just to make sure that the data is nice and clean before we run any analyses or reporting on it. So for example, we'll look at things like CPT codes, or, is the service a Medi-Cal covered service, is it a duplicate record, et cetera. And then once those records and those issues are fixed and addressed, then what we do on our end is that we'll generate a suite of reports, there are about 14 total, and then we redistribute those back through the secure FTP site. And these 14 reports basically fall under 5 main categories. We look at enrollment, we look at inpatient visits, we look at ED visits, we look at physical health outpatient visits, so any primary care visits or specialty care visits, and then we also look at behavioral health. And behavioral health really is a new kind of module for us to look at, but it's pretty exciting. So the third piece of this, of how we want to look at our data, is understanding the resources that go into supporting our workflow process. So on the county agency end, in addition to myself, we have 2 main analysts who manage the database, or what we're calling our medically indigent care reporting system, or MICRs, and they also generate the reports that I had mentioned earlier. But they're also available to provide any technical assistance to our contracted providers as needed. Then on the local clinic end, we have what we're calling a single point of contact, or SPOC network. And that team includes at least one person from the IT side, and that person's responsible for uploading the data every month and downloading the reports for distribution. And then there's a SPOC for the physical health data specifically that really manages just the physical health reports. And then we have their counterpart that looks at just the behavioral health reports as well. It's a great network. I do have to say that there are some challenges with this structure because keeping it updated is a little bit tough, you know, if you have turnover or people are in and out. But because it really supports a streamlined communication pathway, triggers really naturally occur when the updates are required. So now we're going to look at or talk about data consumption and answering the question of how do we use this data. I'm going to make a few brief comments, and I'm going to go ahead and turn it over to Cheryl Northfield to talk about some of our latest work. There are currently two main applications of how we use this data. The first is similar to San Francisco, is looking at decision support and strategy development for the program itself. So for example, if we want to look at things like access to care across the network, we might want to look at particular metrics around third next available or capacity expansion activities, or we might want to really focus in on utilization by looking at frequent users of the ED over a set period of time. The second application has to do with an administrative function because reporting is a very critical part of our contracts with our providers. So we do actually have incentives in place to ensure that, number one, we even just get the data every month before funds are released. And then also, too, we want to look at milestones and targets that are met for any of the key measures around utilization. So that brings us to our latest work that's made possible through Blue Shield. The grant that we received provided the opportunity to build capacity that includes reporting on quality measures to complement the utilization metrics that we already have in place. So we originally proposed a 4-step process for accomplishing that over the course of 12 months. The first phase included assessment, and that was looking at existing metrics within our contractor network. The second had to do with design and organization, so we wanted to identify any overlapping metrics of interest between both the agency and our contracted network. The third had to do with collection and analysis, so we want to make sure that we start to actively begin some of this data so that we can also establish some baselines. And then the last of these has to do with summarizing the results to monitor our progress. So now I'm going to turn it over to Cheryl Northfield, who is our consultant with CNC Advisors and is partnering with us on this work, and she's going to provide us an update on the work to date.
Thanks, Shailani. This is Cheryl Northfield. So thus far in the project, we have identified 3 measures to pilot. Third next available appointments, A1C for individuals with diabetes diagnosis, and high blood pressure for individuals with a hypertension diagnosis. So the first measure was identified by the organization out of access concerns, and then the next 2 measures were identified out of the landscape assessment that we recently conducted. So in that process, we interviewed county stakeholders, so the FQHC Consortium and their clinics, as well as the contracted county hospitals. We also interviewed several Bay Area and health plans, and also LA County health plans who are delegated to manage Medi-Cal programs. And what we learned from them is that to date, there really hasn't been much effort put towards quality improvement for clinical measures in this non-Medi-Cal indigent population. What their focus really has been is on tracking measures for their Medi-Cal population, which is for the most part driven by HEDIS. So it really makes sense, we decided it really makes sense to delve into this effort to also track HEDIS measures so that there's consistency in effort and also in reporting, and has ample access to consistent benchmarking. So A1C and blood pressure were selected out of this, the whole list of HEDIS measures because our FQHCs are focused on improving social determinants. They had a grant And so they used this grant to look at hypertension and diabetes. Hypertension is 30% of the total population, and they found that most of their high utilizers have a diabetes diagnosis. Through this interview process, we asked the interviewees how they are able to influence success in these measurement programs. And first off, they said it helps to have provider input on both the selection of the measure and the data collection process. They also said that there really isn't a magic bullet for improvement, but the act of reporting on a measure seems to have some influence. They also said that you really need to be cognizant of the repeated effort it takes to sustain programs like this, both on the plan side and on the provider side, and just knowing that to keep those resources in place, to take it into the future, or you need to come up with a way to change the process or automate it. There also was some emphasis on the fact that there's a dearth of provider resources to support these programs, and that they really need motivation to do this. So on the provider side, you know, you may need to offer some sort of pay for performance program. Some of the plans are offering incentives on the patient side as well. But they cautioned us that once you offer an incentive, it's very difficult to take it away. Two last things they mentioned. It's really helpful to do at least quarterly or monthly reporting on these measures if possible. In the HEDIS world, typically they come back with an annual report. It's good to be able to influence things along the way. And then lastly, they said it's okay to fail. What's important is you look at the information that you've received, evaluate it, and look at how you can improve for the next year. Just a quick update on where we are in the project. We've developed and agreed upon a file format with the SQHCs and the county hospital. We're beginning file processing and report development discussions, and we expect that we will process live data in August of this year. So I'd like to hand it back over to Bonnie.
Great, thank you. Let's turn it over now to Maura to tell us what's happening in Monterey County. Before I do so, though, I'd like to remind you to submit questions in the question window on your screen for our question and answer period. So Maura?
Okay, so compared to the previous speakers, we're kind of newer in this whole process. We are just starting a pilot project that started last November. I am a project manager here at the Clinic Services in Monterey County Health Department, and we're going to walk through some slides on how our launch has gone so far for the project. And also I should note that I was brought into this position by a grant that my boss received from Blue Shield specifically for implementing a pilot project for this effort. So we started officially engaging clients and customers on November 1st, and as of last week we had over 800 people enrolled. I should back up and say that the county supervisors here in Monterey agreed to long conversations with a local religious and labor group called COPA that was saying, you know, our people who are not qualifying for other existing healthcare programs and who work in hospitality and in agriculture are suffering from not getting more comprehensive medical care. And so the Board of Supervisors agreed to put aside $500,000 for a trial period, and it's basically until that money is gone. And so we weren't really sure if we were going to run through the money really quickly. We decided to just offer a sub-list of lab services and a small list of radiology that we would have done at our local participating clinic. we are a lookalike federally qualified health center. We have 7 clinics that we are using in our pilot, so everybody has to stay within our county network. And then we use the 1 hospital that's within our system as well to do the labs and the x-rays. So now let's look at some of the demographics that we've gotten just in the last 6 months or so. We've seen more women come forward than men. When I asked the clinic managers if they had any comment on that, they laughed and basically said that's what they see in the clinic itself, so to them it seemed normal in that way. I'm not sure if it's just the women sussing out the pilot first and then reporting back. We're starting to see all different ages come in. As of May 16th, we started to encourage the 18 and under patients to take advantage of Medi-Cal now that that's available. So we sent letters to them and are asking them to please sign up. We have people at the clinics who can help anyone sign up for Medi-Cal when they come in. The next slide talks to income, and our pilot project is available to people who are at 138% of the FPL, just a little over $16,000 a year. So far, as you can see, a lot of our people are way under that. We asked them when they sign the consent form for the pilot to also sign up for our sliding fee scale that's offered at the front desk for all patients. So some of the people who haven't been verified on what their income is will be in the pending file here, but we have very few people that we have to send letters to saying that you don't make you make too much money to qualify for this program. And then on our next slide, we'll look at where they're coming from. This is pretty indicative of where the folks live in our area. We're trying to get more marketing out to the different aspects. Right now it's word of mouth. The COPA organization at their church meetings and in-house meetings has talked about the program and given out flyers. We're doing a brochure for them. But so far it's just word of mouth, public radio, and it seems to still be taking off quite well. On our next slide, we'll look at the most common diagnosis that we've seen, which sounds like the rest of the areas that we've heard on the call today. When we started this program, talking with our medical director, we did not want to selectively pick diagnosis because that felt discriminatory. So we tried to just aim for most common types of causes or most widely prescribed medications, and then this is the correlating diagnosis that's going with those prescriptions and x-rays. So diabetes, hypertension, obesity, a lot of the same problems you're seeing. We were a little surprised by the depression and anxiety, so we actually augmented some of the medication lists to cover those as well. And then we broke it out by where people are going. As I said, we had 7 clinics. 4 of them are within 1 location at Laurel, so I just started grouping them by 1 place. And again, it's a little bit based close to where people live and take public transport to get to the clinics. And we are partnered only with Walgreens, 1 pharmacy place, to work on our 340B list, and they've been a really speedy and helpful resource for us. We also use Epic to mostly pull our data. At this point, that's our medical records so far, and we're starting to look at do analysis so far just from within Epic. Then this will be the most common lab and x-rays that are recommended. And again, they match up with the diagnosis that we're seeing on the previous slide. That's a lot of manual manipulation by my IT person and myself looking at Excel data every Monday. And then another way that we're looking at the data now is sort of the overall health status. So again, we're looking to the things that we ask them when they come in at the time of their visit and their overall determinants of health, like do they have adequate shelter, any kind of disturbing, violent background or any stressors at home. This is the kind of metrics we're able to pull right now. We're also hoping to get some data out of the state to correlate PM. We have some idea for Medi-Cal, obviously, like you all do, but we were looking for any data that the state might have on our unrestricted Medi-Cal users. And we are so far not successful with getting anything from them at this point. On the next page, we're looking at the costs. We started off a supply list in all the clinics. We wanted to be able to give people inhalers and test strips and any of the more basic diabetes supplies that would be a pain for them to get, ongoing, and that they'd have to absorb the cost. We want them to get a kit running and at least start to do a 3-month check and not have to be going out to the Walgreens or running out and coming back into the clinics. So we were very pleasantly surprised that this far in we've only spent a little under $50,000. We were hoping to ask for more money, but I think at this point the Board of Supervisors is saying, well, I want you to keep doing what you're doing and report back. We go back quarterly to them with a chart on how we're doing, and so far they seem pretty happy with the results. So that's it for me, and back to Bonnie.
Great, thank you, Maura. Thank you, Maura, Shailani, Cheryl, and Alice for those insights and for taking time to share your learnings with all of us today. We will now open things up for questions. As a reminder, if you would like to ask a question, please do so by typing it in the question window on your screen. Unless specified, we'll distribute each question to the most appropriate speaker to answer verbally. The first question I'd like to start with, sort of recognizing that all of you are in different stages of collecting and reporting on the measures for your program. I wonder sort of if you had the opportunity to go back and start over, sort of knowing what you know today, what would be the top 1 to 2 sort of data points or measures you would definitely be sure to include, whether or not you are collecting data on those measures now? So let me start, I think I'll go in order. Let me start with Alice first, if you'd like to respond to that.
Sure. I think that one of the things that we've noticed is the importance of clinical data and the difficulty it is to often change the way we collect clinical data or the way we analyze the data. So I think if we were to go back with sort of the knowledge we've gained through the years, I definitely think we would want to have the clinical data in terms of encounters and sort of how we collect and how we classify. I think we would definitely want to think about them a little bit more so that we are not seeing some of the gaps that we currently have and have to sort of make inferences.
Great. Shailani or Cheryl, do you have anything to add?
Yeah, we have a couple of thoughts, actually. I think in terms of if we could go back and restructure our database, a couple of things that we would really be focused on up front is making sure that we are receiving accurate data on a patient's medical home and also their PCP assignment.
Mm-hmm. And yeah, I'd say that. And then just to add on to that, some of the things that we are currently providing now around quality and access, it would have been nice to start collecting that from the very, very start, but I'm glad that we have the opportunity to collect that now.
Great. And Maura, anything to add?
I was just writing notes on what the others were doing for collecting data and adding, like for myself, we have a patient survey that we ask for. We're just getting up on our website, and it never occurred to me to offer that as well to our pilot people, which is a great idea. And as far as I'm just more concerned with, we're going to need more staffing, both in the clinics, because we estimate between 30 and 50,000 people could qualify for this program. And then on my own end of doing the reporting and looking at the data, if I start approaching your all numbers of thousands, it's going to be a couple people doing what I do. But I'm very grateful to be able to learn from your experience on these.
Great, thank you. So this question, I think I might start with Alice for this question around clarify or tell us sort of what the lag time is for the data that you collect regarding enrollment and service utilization, and if you know sort of any of the underlying factors for that lag time.
Sure. So for the demographics around enrollment, we do have a web-based enrollment and eligibility system. So in terms of the data around who is in our program, those are real-time data that we do have. So we are very confident about that. The only thing we may have is inaccuracies from data entry or duplicates that are inadvertently created. In terms of the clinical data, we do have lag. So similar to Alameda, we have certain requirements with our contracted providers that they submit an encounter on a monthly basis to be paid for their services. However, as the population dwindles due to people moving into ACA options, we do have providers who, may not take our program as a primary focus. So, there may be lag in the data submission, even though there is a requirement to submit that for payment. And sometimes the other thing which we've encountered is as we've grown and we've become more aware and try to implement things to make the data exchange more complete, more accurate, more in line with other lines of business, we've been trying to improve those feeds. And sometimes that requires a lot of back and forth between our providers who are submitting encounters with our TPA, third-party administrator, who receives those encounters. So sometimes there's a bit of lag due to the technology part. And that can really vary depending on the workload of the individuals that need to be involved to address any issues.
Thank you. Shaylani and Cheryl, do you have anything to add to that?
I'd say that the process is pretty similar. It's typically, and we're on the same system, right, as San Francisco for enrollment. And in terms of utilization data, it is usually about a 1-month lag. Sometimes, though, it actually might be a little bit more because we do give the opportunity to our contracted providers to submit previous data. So, for example, if we're in May and a claim had finally gotten processed from a few months prior to that, they can update that information. But it's typically about a month.
Great. So the next question I will direct actually to Shaylani and Cheryl around sort of the comment that you said that beginning in August, you'll sort of process the live data. Can you talk about what that means in terms of sort of how you or the community will use this data and what your plans are sort of moving forward? Is this sort of a point in time, or do you plan to continue collecting this data over the long run?
Yes, definitely. So we will be receiving our first round of files containing July data in August. And so that's really going to serve as our first month of baseline data. We're going to generate reports and share those reports with providers. We'll be comparing the information with the HEDIS benchmarks, but really, it's going to take an accumulation of months before we can really see where we are on an aggregate level.
But I do want to add that once we do get into a rhythm of collecting this data, that once we're able to look at what it looks like for our health pack population and being able to marry that with what's currently being collected with the Medi-Cal population, we'll have a much more comprehensive look of what's going on in the community for the whole county, for our total network. Whereas right now, I think we're getting this information fairly separately.
Thank you. Maura, I'm going to direct these next two questions to you. I'll put them into one question. The first question that came up is around, not necessarily related to data, but is about the program and how Walgreens became sort of the only participating pharmacy and how that relationship was forged, if you can speak to that. And then the second question is around tracking the health status, so that the smoking, the alcohol, is that just a point in time, or do you plan to track that over time with the patients?
So the Walgreens question, we already had a contract with them to provide our 340B prescription medications, and so it was easy for us just to leverage that relationship and say, will you help us make a subset of this that goes for the pilot people? So mostly it was convenience for the patients, and then we already had that relationship. And then the question around tracking health determinants, we right now are just doing a snapshot, but we will track those measures for the individuals over the course of their time being in the pilot program. And we're pulling that from our EPIC, our medical record software.
Thank you. This question, next question, is for all of you, and it's around, we've talked a lot and heard in your presentations around how data, what you're collecting, is being used certainly to improve the program, to make business decisions. I'd like to turn and talk, maybe have you respond to sort of advocacy and how the data that you're collecting and analyzing is moving beyond your own programs, maybe, county department, to the broader community, and how your community partners, I think, Maura, you mentioned COPA, sort of how they are accessing and utilizing the data to perhaps advocate on behalf of the remaining uninsured. So maybe I will start with Maura for that, and then I'll go to the others.
So every week I update my the slides basically that you just saw with weekly data, and then I send it over to our partners at COPA. They have been doing a lot of outreach at their church meetings and their management meetings for their organization, and then they have done one-on-one meetings with the county supervisors to try to move the services to the next level, maybe add specialty care or maybe expand the covered medications list. So it's hugely helpful for us to have them out in the community doing that. We just don't have the bandwidth in the county to be doing that. So that's been a big plus for us.
Great. Shailani, Cheryl, anything to add?
Yeah, I did want to mention another one of our partners, in addition to our directly contracted providers, is the Alameda Health Consortium, and they're an organization that I guess represents the FQHCs, and we do work closely with them, share data with them as well too, and so they have access to the data on the health pack population if needed, if they're having conversations with other community partners or with the Board of Supervisors as well too. So there is a lot of kind of sharing within, not just with the county and the providers, but with other organizations too that are part of this larger community.
Thank you. Alice?
Sure. So I think our program has not been directly involved with a lot of advocacy in terms of just the program itself, but we always want to make sure our data is available to those who are working with our population. So we provide updates to our advisory committee on a quarterly basis around enrollment, around program updates, and these include stakeholders from internal as well as the community. We also provide updates to the Health Commission on an annual basis, and we do take a look at the data ourselves to look at how is this program working for the people who don't have other options for health care. And so we have made certain changes to the program to continue to address that goal. including the expansion of the program's eligibility to those 65 and older after ACA was implemented, because folks had the data knowing how many, that there were many people who were in our program and prior to our change in policy had to be disenrolled after they hit 65. We also used the data as a way to, that was a way of determining, how do we expand coverage and help to reduce barriers for those who are eligible for Covered California, but because of the high cost of living in San Francisco may still be unable to afford the premiums and thus are still remaining as uninsured. So, so I think we do a lot of data sharing and data presentation to groups, letting folks know about the program, and then as well as internally looking at where we can continue to make improvements on the program to meet the needs of the goal of ensuring everyone having access to care.
Thank you. The next question I think has been addressed through a couple of comments, but I still like to ask it, which centers around sort of how you're using data to measure access to care for patients. So the question asks, are there enough providers in your program? Are you finding out if patients are having any trouble getting into care? And then I think one of the measures that's of interest is, does anyone measure the average length of time to get services? So Shailani and Cheryl, let me start with you to have you address that first.
Sure. In Alameda County, the measures that we currently have in place, I guess that would attempt to measure access would be around third next available appointment. And we look at that for both, we look at that in two groups too. We look at it for new patients, for existing patients, and then looking at those same populations, looking at the measure including same-day appointments and then excluding same-day appointments. So I guess that's really like 4 for each one. And then the other piece that we look at is around capacity expansion activities. So like in the last contract year, we had built in some, I guess, incentives or some activities for providers to build some type of a program to increase access to their clinics, and we really left it up to the providers to determine what that is and so that they can cater it specifically to the populations that they serve. So it could have included expanding their hours, for example, or something like that. But around access, those are the two main measures, really the capacity expansion visits, looking at that, and if that's shown any improvement, and then also their next available appointment.
Thank you. Maura, would you like to comment?
I would comment that we're not currently measuring the pilot people specifically for access, but I know that we are tracking just for HEDIS measures and that we are aiming to add shifts and open a new facility because we are just at an overcapacity already.
Great. Alice?
We predominantly measure access through our grievance process. We do measure our own network's access. We treat patients regardless of whether they are indigent health access program or Medi-Cal or any other lines of business the same. So we do, as part of our own network quality improvement, we do measure our access and capacity. And so we would expect that that would be very similar across the board for all of our patients. But we do collect information and track all of our grievances and complaints. And we have a process by which individual medical homes can close their medical home for new patients when they have reached their capacity, but we do allow the individual medical homes to make that decision. And if we do receive complaints of being unable to access an appointment or a particular service, our customer service and provider relations group does reach out to the provider and try to address those issues.
Thank you. This next question is directed towards each of you, and the question is whether or not any of you collect or identify if your enrollees or patients are homeless. So Alice, let me start with you.
Sure. We do identify, and we identify the type of homelessness that they are, whether they are in a transition housing or a makeshift vehicle. So if a person is homeless, we do ask that of all applicants, and they may answer, yes or no. And then if they do answer yes, we do ask them what type of homelessness they are.
And does this data make it into the annual report that's available?
I believe this data is not in the annual report specifically called out, but if it was ever requested, it's something that we can easily pull up.
Okay, great. Thank you. Shailani and Cheryl.
Yes, we do track homelessness. It's collected at the time that they apply for coverage or renewed. We ask for their address, and at that point they can identify themselves as homeless, and then we do try and collect a mailing address if possible, or if that's not available, then we try and use a local social services agency address.
Mm-hmm. And I also know that in that housing status is also collected at certain behavioral health encounters as well too, so that's another point of access to that info.
Thank you. And Maura?
We also are asking that question at the office visit, and if it's warranted, they're referred to social services, and I believe also behavioral health asks that as well. We will be adding it to my charts of determinants of well-being.
Great, thank you. This next question is directed to Alice. In your presentation, you mentioned that Healthy San Francisco does not do rigorous quality control on the data that's received. The question is, was this an active choice that was made after weighing options, a reality of staff bandwidth, or something else? And sort of moving forward, do you expect that you'll address this challenge?
Sure. I think this was an active choice. We try to do certain measures to make sure that the quality is better, but in terms of data accuracy, we don't have a way to really verify certain things. So, for example, we ask that a provider at the end of the year report to us their costs. There's really no way we would be able to audit the costs that they report to us as whether they're accurate or not accurate. And in the same way of the data in the encounters, so we we have a capitated arrangement with our providers. So there isn't really a good way to audit and be able to identify if a provider told us they had 600 services that month. There's really not a good way for us to identify whether that's a complete picture or if there are other missing encounters or visits that they saw for our patients. And I think that is a issue that we are going to continually face. On some of the other issues of data elements being in the file, those are issues that we are working to address and to continually improve our data, but just sort of that accuracy of, is it capturing all of the universe? I think that's something that we just are not going to be able to really verify.
Thank you. The next question, I think I will start with Maura around, and then Shailani and Cheryl, which is around collecting whether or not your program either currently collects or you plan to collect sort of patient satisfaction with services. So if you could, Maura, start and either let us know if you're currently collected or if not, if you plan to collect that data moving forward.
We currently do not, but I did make that note when the previous speaker was talking that I would like us to offer that patient satisfaction survey to our pilot people.
Great. Shailani and Cheryl? Oh, sorry.
No, I was just saying we will be.
This is Cheryl Northfield. It came up during our research amongst the health plans and providers, and the thing is, with under the HEDIS CAPS reporting, they hire an outside agency to do an annual satisfaction survey, so that you don't have any artificial influences. Originally we thought, well, gosh, maybe we could add it on at the enrollment process, but I think it's hard to get a real uninfluenced response when someone from the provider location is asking questions about their service when they actually are the service provider.
One thing I did want to note too was that some of the results from a patient voice project that we had done, which was also another Blue Shield grant last year, was thinking about going forward, how could we collect patient satisfaction information, not necessarily in the provider setting. And one idea that came up that we may explore is doing a patient satisfaction survey at the time of, say, re-enrollment, for example. So we might be able to capture that information when people are coming back to renew their enrollment status, regardless of whether they're utilizers or not. That might be a good point as well, too.
Thank you. Alice, any comments?
Not really. We are collecting the satisfaction as part of our survey, and I think it's been working out pretty well for us, that we've had 8 years of data now. And we do analysis of the patient surveys and do comparisons among people who have been repeatedly in our program around the enrollment period. So.
And may I ask, are your surveys offered in multiple languages?
So our survey is, so the survey itself is, the questionnaire is in English. It is a part of the enrollment process, and we have, we don't have self-enrollment. So everyone who enrolls in our program they do their enrollment with an enrollment counselor. And so the enrollment counselors, we do have language capabilities. And so the enrollment counselor would basically be asking the participants the survey question in their language, and then they would then check whatever response the participant gave.
Thank you. Shailani, would you like to add anything?
Oh, sure. I just wanted to make a quick point of clarification from my response earlier. I wanted to note that people can enroll in HealthPAC both at the local clinic, which is a little bit what Cheryl was talking about, but you can also enroll here at the agency setting. So that was really what my comment was geared towards, is like if we did any re-enrollment here at the agency, that would be probably an appropriate place to do a patient satisfaction survey.
Great, thank you. So I'd like to take this opportunity to ask this last question of all of you, which is, as you've been looking at your measures, collecting or just beginning to collect data on these measures, as you look to the data, are there any surprises or learnings from your data with respect to demographics of enrollees or patients or utilization or patient experience that have surfaced? And if so, are you doing anything, either if they've been opportunities or challenges to address those surprises or learning? So let me start, Alice, with you.
Sure. I think one of the things that we're very interested in is really trying to understand what the utilization of our population is. And so I think before ACA, when we had all of these patients that were in our program and they didn't really have they didn't have a full insurance program, we looked at the utilization and we thought a certain way about, that was our baseline and that was kind of what we thought our utilization was. And then once ACA happened and we had a different, some of those populations then transitioned into Medi-Cal but still remained with us. So we're really interested right now in kind of really understanding and doing some looking back at, were we really accurate? Were we capturing what we thought our groups were they the same utilization now that we have a payer that really captures a bit more comprehensive services? So I think that that's one of the things that we're going to be looking at really very interestingly. In terms of our demographics, I think our demographics for our patients over the years, with the exception of ethnicity, has not changed very much. So prior to the ACA, we had predominantly very low income, most below 100% of FPL, and a young, 25 to 49 majority group, and that still remains the case, but our demographics have changed significantly, and I think that reflects sort of the population that is not eligible for new programs. So I think those are kind of interesting things that have come up for us, or we're interesting things that we're hoping to really take a look at going forward. But other than that, I think we're constantly trying to understand from our data who we have and where they are and what kinds of services. Are they sicker? Are they getting sicker or not sicker? But we haven't. There hasn't been anything that has been especially surprising for us.
Thank you. Maura, anything you'd like to comment on?
Ours is still so new that we're still trying to figure out what's normal, but we were a little shocked and dismayed to see how many of the people are under 100% FPL. We were originally kind of haggling about what the cutoff point should be. So we were at 138 or 200 or whatever, so we settled on 138. But so that was sort of an eyebrow raiser a little. So far the rest we're still just learning as we go. I guess a little bit we were focused more, I think, on physical medical conditions, and so seeing the depression and anxiety stuff come in, we were quick to try to get some help for those people as well.
Thank you. Shailani and Cheryl, any surprises or learnings from your data?
I would say probably, I don't know if it's a surprise, but I noticed in the data when we were looking at chronic conditions, for example, less than a third of the population, well, first half of the population is utilizing it. Of that half, a third of that population have chronic conditions that are related to them. I guess I would have thought it would have been a little bit higher, but I'm not quite sure if that's a result of a data issue, or if it really is that it's a healthier population in general, but I just thought that was an interesting point.
Thank you. We are now out of time for today's webinar. On behalf of the Blue Shield of California Foundation, thank you all for a great discussion this afternoon, and a special thanks again to Alice, Shaylani, Cheryl, and Maura. We encourage you to connect with one another outside of this webinar to continue learning from each other. Feel free to get in touch with any of our presenters today. We have their emails included in this presentation, and their contact information will also be a part of the presentation that is posted on the Foundation's website. This concludes the webinar and the remaining Uninsured Learning Series. Have a great rest of your day.